Welcome all. On behalf of Maha-IP, I welcome all executive members, all delegates, speaker, and all CIP members. Welcome to the session of All About Iron. Iron is very important for body, for growth of child, as well as iron is also important antenatally for the growth of baby. If it is lacking in diet, then most common we are seeing is iron deficiency anemia. Iron is essential nutrient that produce hemoglobin. So let us know about the iron, and here our speaker will teach us all about iron as a case-based approach. So I welcome Dr. Gangulia sir, our President Maha-IP, Dr. Amol Pawar sir, our Secretary Maha-IP, Dr. Jay Bhandarkar sir, our Convener Maha-IP, and I welcome our esteemed speaker, Dr. Tushar Idhate, Pediatric Hemato-Oncologist from Aurangabad. I welcome my co-host, Dr. Reena Rathi madam. She is from Nashik, and I welcome Dr. Neha Singh. So welcome all. I would request our president, Dr. Hemant Gangulia sir, for his presidential address.
Thank you, madam. Good evening and namaste to our respected guest speaker, Dr. Tushar sir.
Good evening, sir.
Our moderators, Dr. Sonali madam, Dr. Reena madam, as well Dr. Jay Bhandarkar, our state convener, Dr. Amal Pawar, General Secretary in absentia, Dr. Neha Singh, the editor of the Maha-IP, as well all the Maha-IP committee and all the viewers on this live channel. Today we are having a topic all about iron. At the outset, on behalf of Maha Academy of Pediatrics, we would like to thank Cachet Pharma for giving an academic grant for this very important scientific session. And we hope that Cachet Pharma will continue to support these sessions, such academic sessions in futures, and we look forward their support as well as the academic support to us. As far as the topic of today's discussion goes, still we see the iron deficiency is the commonest cause of the anemia from infant to the geriatric, all throughout the life. And still we struggle to treat the iron deficiency anemia. Though it is the commonest, but still we miss few of the things which are, so we keep on treating with iron, but it doesn't respond, and we miss other hemoglobinopathies and etc. The other causes of the anemia. But being the most commonest iron, still we struggle by giving iron, which salt to give, how to give, when to give, and what doses to give, and how to follow up. And many times the compliance is the issue. And it's all these things, we so many decades we are discussing iron deficiency, but still we are struggling to treat the iron deficiency. I hope so with the renowned speaker amongst us, we will be able to get the clear-cut messages, what salts to be used, what dosage, when to use, and when to suspect, in spite of giving iron adequately, the anemia is not responding. So we have to think the other side of the coin also. Hope so this session will be fruitful, and let us learn all things about iron. And before he starts, I would like to say one more thing. Probably in our old days, we used to cook our food in the म्हणतात ना लोखंडाची कढाईमध्ये आपण हे बनवायचं, आणि कदाचित ते आपण परत करायला पाहिजे. लोखंडाची कढाईमध्ये जर आपण परत हे जेवण करायला लागलो तर कदाचित बऱ्यापैकी आपला आयरन डेफिशियन्सी कमी होईल. मला माहित नाही, पण मला असं वाटतं आम्ही लहानपणी तर आम्ही बघितलंय आमच्या घरात आयरन लोखंडाची कढाईमध्ये आपण जेवण बनवायचं. तर कदाचित लेट अस हिअर फ्रॉम द स्पीकर. अँड बिफोर आय आस्क मॅडम, Dr. Jay, if you want to add something, and then we'll go to Madam Sonali back.
Thank you, Dr. Hemantji. At the outset, good evening to all, and welcome this very important session. We know iron deficiency anemia is the most commonest hematological disorder in the pediatric, maybe all over the world. And iron not only important given iron deficiency anemia, it has own role in different it has own functions. Even we use in breath holding spells also, right? So, and a lot of preparations are available. A lot of I can say sulfate, phosphate, biglyceride, and ferrityl iron, these this process. So sometimes we are confused which I should use and how to use, because every has different composition of element and ion as well as absorption is different. When to give, how to give, this is very, very important. And just I want to share our case. Recently, I was treating a case as a and we see anemia, and that patient failed to respond to me after even after 3 months of continuous giving the iron. Two cases. Last 1 year I came across. One turned out to be some GI loss due to cow milk protein allergy, and second turned out with thalassemia trait. So this thing is very important. Only low hemoglobin, not always iron deficiency. Something else is also always possible. So I know Dr. Tushar is an expert hematologist, peri-hematologist, and you're going to give with pulse of thoughts for this very important session. I can thank Dr. Tushar for his accepting invitation from the MAHA-AOP. As well as thank Cachet Pharma for starting some sessions which are very relevant to us. So, whereas the organizer, again, I welcome all of you for this important session. And please put your questions in the chat box. Thank you very much. And over to Dr. Sonali and Dr. Reena for further proceedings. Dhanyawad.
Thank you, Gangulia sir. Thank you, Bhandarkar sir. Now, moving on to our session, all about iron. I would hand over mic to Dr. Reena to know about our speaker in details and will guide us.
Thank you.
Reena ma'am.
Thank you very much, Dr. Sonali ma'am. Good evening to all. Our today's speaker, Dr. Tushar Idate sir. Sir is a pediatric hemato-oncologist from Aurangabad, practicing there since last 6 years. Sir is first pediatric hemato-oncologist in Marathwada and Khandes region. We are proud of you, sir, and we are very fortunate to have you in that region. Sir has done his MBBS from BJ Medical College, Pune, and postgraduate in pediatrics, MD pediatrics from Sion Hospital, Mumbai. Sir is having has the international fellowship from London Children's Hospital, UK, St. Jude Biwa Forum Fellowship, Singapore, Fellowship in Pediatric Hemato-Oncology, Apollo Hospitals, New Delhi. Sir has taken specialty training in pediatric oncology from Tata Cancer Hospital, Mumbai. Sir has been faculty at multiple regional, national, and international meetings and has many publication index in various journals. With that, I would like to welcome our esteemed speaker, Dr. Tushar sir. Over to you. Thank you very much.
Good evening, everyone. And at the outset, I would like to thank MAHA-AOP President Hemant sir, Pawar sir, and Sonali ma'am and Rathi ma'am for inviting me for this session. I think we are already late by 10-15 minutes. So without wasting time, I will start with the session. I will share my slide. So already the base has been formed by the sort of at the time of introduction only that iron is very important, and we know that iron deficiency is very common in our country. So this is going to be the sort of outline of my talk. I have tried to cover some of the basic things while some of the advanced things. I will brush up what we already know, and I will try to add few things to your knowledge. So basics of iron metabolism we will be discussing. I have tried to incorporate some cases also so that it doesn't become too boring. We are going to discuss about iron refractory iron deficiency anemia, because we don't know when patients do not respond to iron. Already sir has discussed very two interesting cases. And what is the role of hepcidin? This is something I think many people must have been knowing, and few those who don't know will discuss it. So we know that there is a very high prevalence of iron deficiency anemia worldwide, not only in our country but worldwide. In developing countries, almost 30 to 50% children who are less than 15 years of age or 18 years of age, they suffer from iron deficiency anemia. This is a National Family Health Survey, and as we can see, less than 19 years, 54% of the adolescent girls and 30%, 29 to 30% of the adolescent boys up to they are suffering from the iron deficiency. And if you see the children who are less than 6 years, the incidence and prevalence goes up to 60%. So we all know that iron is used for different use in our body. 75% of the absorbed iron is bound to the protein such as hemoglobin, which is involved in the oxygen transport, and 10 to 20% of the absorbed iron goes in the storage pool, and it is again recycled and used for erythropoiesis. So basically, there is a balance which is maintained via absorption, storage, and excretion. This we have discussed that 70% of the iron will be used for hemoglobin, but it is also required for myoglobin enzymes. And there is almost 70 milligrams per kilo of iron which is stored in the body approximately. For adult male, it goes to 4 grams, and adult female, it is approximately 3 grams. So iron is not required only for delivering oxygen to the tissues, but it affects our physical performance. It is also required for thermal regulation. It is required for the cognitive function as well, and it affects the immune function of the child as well. So as sir was already discussing that, लोखंडाची जी कडी आहे त्याच्यामध्ये कदाचित iron असेल, तर definitely there is iron in that. So we all know that there are two forms of dietary iron. So iron which we will take through the food, there are two forms. One is heme iron, which is found only in meat, poultry, seafood, fish. So basically it comes from animal proteins in our diet. So we can call it as a non-veg iron. And there is something called as non-heme iron, which is found in plant-based foods like grains, vegetables, beans, fruits, nuts, seeds, dates. Okay, so this is a non-heme iron which we can call as a vegetarian diet. And of course, we know that so-called non-vegetarians always eat veg. So similarly, the non-vegetarian iron is also found in animal meat. So basically, लक्षात ठेवण्यासाठी सोपं आहे की एनिमल मीट जे आहे, नॉन व्हेजिटेरियन जे आहे, त्याच्यातलं जे आयन आहे दॅट इज हिम आयन, while the veg जे जेवण आहे त्याच्यातलं जे आयन आहे दॅट इज अ नॉन हिम आयन. Why we are emphasizing this is because the heme iron is very easily absorbed, and therefore it is a large source of dietary iron. While the non-heme iron, which is predominant iron in a vegetarian diet, it is usually less readily absorbed. So megaloblastic anemia, we always had the insight that it is common in vegetarians, but even iron deficiency anemia is relatively common in those who are predominantly vegetarian compared to those who have non-vegetarian intake, because the sort of type of iron which is available in a non-veg diet. We all know this, that vitamin C enhances bioavailability of iron, whereas phytates, which are there in the grains and beans, then certain polyphenols, then concurrent administration of the calcium, all these things inhibit absorption of iron from the gut. So typical daily normal diet contains 10 to 20 milligram of iron, and out of this only 10% is absorbed, which comes to 1 to 2 milligram per day. And most of the absorbed iron is used in the bone marrow for the erythropoiesis. Okay, and the iron hemostasis is closely regulated via intestinal absorption via hepcidin. Now this hepcidin, I have put it in the red. We will discuss it in further course. So once the iron is absorbed in the body through the gut, there is no physiological mechanism for the excess iron to be excreted out of the body. Okay, so this is the reason that there is so much of iron overload in the thalassaemic patients, because physiologically, like water soluble vitamins, we know that there cannot be overload because they are excreted in the urine. Unfortunately, there is no physiological mechanism for excretion of iron through the body. So this we have already discussed. As you can see in the gut, 10 to 20 milligram of iron is sort of daily intake. Absorbed is 1 to 2 milligram per day. Transferrin, as we all know, is used for transporting the iron through different organs. So this transferrin will transport 75% of the iron to the bone marrow, and it will be used for the hemoglobin synthesis or erythropoiesis. Some of it will be stored, 10 to 20% of it will be stored. And storage, we know it is made in the ferritin, and it is stored in the liver and heart. And 5 to 10% will be used for myoglobin and other protein synthesis. While 1 to 2 milligram per day is absorbed, most of it is excreted in the same manner or in the same quantity through the desquamation of the epithelium cells of the GIT. So almost same amount of iron is excreted. So there is a balance which is maintained. So there is no iron overload as well as there is no iron deficiency. Still, we know that iron deficiency occurs and it results into anemia. So anemia is, we all know it is a reduction in the hemoglobin and ultimately it results in tissue hypoxia due to decreased oxygen carrying capacity. But we know that even before development of anemia, iron deficiency can lead to impairment in the mental and motor development, poor concentration, poor attention, distractibility. Physical performance of the child is reduced. It leads to poor motor skills and productivity. And it also leads to a decrease in the school performance, and school dropouts also can happen. So basically, not only the anemia, but even before the anemia, iron deficiency has got very huge impact on the health of a child. So now, rather than making or continuing it in a too theoretical way, now we'll discuss 3 cases where we can see in all the 3 cases, hemoglobin is 5.8, second case 5.5, and third case it is 5.5. So all 3 are cases of anemia, and we'll take 1 case at a time and discuss how the iron is relevant in our day-to-day practice. So 2-year-old boy coming to you with respiratory infection, you have noticed that the child is pale, liver and spleen are not very significant, and you have done the CBC of the patient. But this is our routine CBC which we see. We see routinely only 3 things. One is hemoglobin, second is WBC, and third is platelets. And we tend to fail to look beyond these things because of our busy practice. But we know there are certain parameters which are very essential and crucial and which can sort of give very useful information. Out of them, one is MCV, second is MCH, third is MCHC. So as we can see in this patient, MCV, MCH, and MCHC all are low. So this is what we typically call as microcytic hypothermic anemia. Then there are 2 more important points which are mentioned at the bottom. One is RDW and second one is reticulocyte count. We know that RDW is a red cell distribution width, and RDW is increased or wide in all cases of nutritional anemia, including iron deficiency anemia and megaloblastic anemia. While the reticulocyte count is called as window to the bone marrow. If the bone marrow is functioning well, reticulocyte count is normal or increased. While the bone marrow is not functioning well, such as leukemia, aplastic anemia, there the reticulocyte count is reduced, while it is increased in hemolytic anemias. So this patient, as we know, looks like clear-cut case of iron deficiency anemia. And the only differential will be, as sir has already mentioned in the introduction, the second differential we should always keep is thalassemia trait. Peripheral smear will give you some clue, but there is not much to differentiate on the peripheral smear between thalassemia minor and IDA. Okay, I am very clear. In thalassemia minor and IDA. Okay, thalassemia major, you can clearly diagnose on peripheral smear. There is sufficient clue. That also we'll discuss. So you will have to go ahead with the iron studies if you really want to investigate this child. We all know that in iron studies, we know there are 4 components. One is serum iron. There is serum ferritin. Serum ferritin is a storage. Then there is a total iron binding capacity. What does TIBC means? Basically, transferrin जे आहे, जे iron transport करणारा जे molecule आहे, ते किती occupied आहे. Okay, that is mentioned by TIBC. So if iron is less, automatically vehicle is empty. Okay, so TIBC will be increased. But if iron is more, TIBC will be low. Okay, so it is inversely proportional to the iron and ferritin. While the transferrin saturation is actually a ratio of iron and TIBC. सोप्या भाषेमध्ये iron, ferritin, transferrin saturation generally एका बाजूने चालतात आणि TIBC exactly त्याच्या opposite side ने चालतात. So in iron deficiency anemia, we are expecting that the iron will be low, ferritin will also be low, transferrin saturation will also be low, but the TIBC will be on a higher side. So this is clear-cut case of iron deficiency anemia. So this is diagram is very actually very good elaboration is made. So normal is mentioned in the left. You can see there is a purple color which is a stored iron. There is a yellow which is transported iron, and erythroid or RBC iron is mentioned in the red. So normally ferritin is normal. Transferrin saturation is also in the range, and that is the reason hemoglobin is also normal. Then there is a stage 1 where there is only iron deficiency, but it has not resulted into anemia. So this will cause decreased ferritin, decreased transferrin saturation, but the hemoglobin will be normal. While the next stage, there will be frank anemia, and here storage iron will also be low, transport iron, which is transferrin saturation, that will also be low, and even the hemoglobin will be low. So this we have to remember. There is something called as inflammation, okay, like HLH and other inflammation or rheumatological disorders, chronic kidney disease and all other disorders where there is an inflammation. This concept is important. There is actually functional iron deficiency. What we discussed just now was an absolute iron deficiency, म्हणजे जिथे खरंच iron कमी आहे. But there is something called as functional iron deficiency which occurs due to inflammation. So what occurs here? There is a storage iron which is there in the body, but unfortunately, because of the inflammation, we are not able to transport it to the RBCs. So your stored iron means ferritin is on a higher side, but your transfer is low, and it results into low serum iron and low hemoglobin. Okay, so basically गोदामामध्ये धान्य भरपूर भरलेलं आहे, पण गाव भुकेल आहे, हा तशातला प्रकार आहे. So ferritin is high, but transferrin and hemoglobin are low. So inflammation results into functional iron deficiency. This is very important concept. Why I will cover. So in absolute iron deficiency, there will be depleted body iron store. Serum ferritin will be low, transferrin saturation will be low, and hepcidin will also be low. We'll come to the hepcidin later on. While whenever there is a functional iron deficiency such as HLH, chronic kidney disease or rheumatological disorders, there will be normal or high ferritin level. Okay, so ferritin in this case is actually high. But if you look at transferrin saturation, it is low. And if you do hepcidin level of this patient, it will be high. So there is no actual iron deficiency, but it is the functional deficiency of iron which is there in the other disorders. And this is helpful to differentiate iron deficiency anemia from other disorders. So we all know that iron deficiency can be because of either inadequate intake of iron, there can be reduced bioavailability of dietary iron, there can be decreased absorption of the iron, there can be increased need of the iron, there can be chronic blood loss. Just now sir has mentioned cow's milk allergy, there can be worm infestation. So this can result in chronic blood loss. There can be non-specific like chronic infections can result. So these are different causes of iron deficiency. So when we have diagnosed iron deficiency, we have sort of come to the conclusion that it is because of sort of dietary deficiency, routine, clear-cut case of iron deficiency anemia. We have to replace the iron. What are the strategies? Most and foremost important is dietary counseling. So we all know that cow's milk had to be sort of reduced. Then you have to sort of junk food has to be stopped. If it is an infant, complementary feeding has not been started, that has to be started. Then iron-rich foods, just now we have discussed, so they should be encouraged in the daily diet. Along with all those dietary changes, what we need is iron supplement from outside. So iron can be supplemented either by the oral route or by the parental route. And if child is in failure, then ultimately we have to give blood transfusion to this patient to replenish the iron. So now this was the hot topic which was discussed in the introduction, that there are different formulations of iron. Ferrous sulfate is there, gluconate is there, fumarate is there, ascorbate is there. There are some ferric formulations also available. Now these are ferrous, there are ferric formulations. So which one is better, which should be used? So unfortunately, there is no head-to-head trial like fumarate versus sulfate किंवा sulfate versus gluconate असे काही ट्रायल्स झालेले नाहीये. But in general, ferrous supplements like ferrous sulfate, ferrous gluconate, these are considered better than ferric. Okay, so absorption wise, whatever is there in the ferrous, they are better absorbed than the ferric. This is first point. Second point, ferrous sulfate and sort of fumarate, we are used to, as a hematologist, we have been trained to use these two. So we are sort of comfortable with it. But I have seen many patients receiving ferrous gluconate and ascorbate, and they are also doing fairly well. Okay, so there is no sort of better preparation, and there is no sort of worse preparation also. The only message I would like to give is, whatever brand you are using, you sort of just check the compliance. Okay, rather than formulation, what is more important is that iron really going in the body of the patient? Is it ingested properly? Is child sort of compatible with that taste? All these are more important than sort of studying too much on these preparations. So all three are good. Whichever you choose, it is definitely going to help you along with the dietary counseling. So we all know that it has to be continued for 3 to 4 months after correction of cause of iron loss or normalization of the hemoglobin. म्हणजे तुम्ही hemoglobin 6 ला जर iron सुरू केलं, तर first you have to reach to hemoglobin of 10, 11, 12. And once you have reached to the normalization of the hemoglobin, from that 3 months are further. Those 3 months are to replenish the stores. आपल्याला ते एक 3 months आपल्या डोक्यात इतकं बसलं की आपण HB 6 ला सुरू करतो आणि after 3 months we stop it. It is hardly gone to sort of 7, 8 or 9, and then we have not even checked it, we have not even sort of documented it, and we stop it. And patient again comes after 6 months or 8 months with the same complaints. So the point is that you have to document it, that hemoglobin has normalized first thing, and once it is normalized, you continue oral iron for 3 months before after the normalization of the hemoglobin. That is very important. So that 3 months are to replenish the store. It is not to treat. For treatment can last for 4 months, 5 months, 6 months also. So we know adverse effects of oral iron. There is nausea, epigastric discomfort, abdominal cramps, constipation, diarrhea. All these complaints are there. So simple way is that I generally start iron after food. We all know that empty stomach with the acidic pH absorption is good, but all these GI symptoms arise because of that. So generally I counsel the family की तुम्ही जेवणानंतर सुरू करा, 8 ते 15 दिवस बाळाला सवय होऊ द्या, and then you shift to the empty stomach. Another way I do is, suppose it is a 10 kg bachchu, you have to give 6 milliequivalents per kg per day of iron, which comes to 60 milliequivalents. Bitcofol ke MC ke water preparation you are using, most of them will give you 5 ml is equal to 33 milliequivalents of iron, elemental iron. So basically 10 kg bachchula 10 ml is your dose. Now 10 ml dose, even if you start in a BD, 5 ml BD, for a 10 kg child, it becomes little bit higher dose, and most of the children do not sort of tolerate it very easily. So it is another way. You start with 2.5 ml BD. Okay, let the child get used to it, and then you gradually build it to the sort of 3, 4, and 5. It might take 1 month for you to go to the 5 ml BD, but that is okay. But that will ensure the compliance for next 3 to 4 months till your hemoglobin is normalized. There are other preparations also which will give you 5 ml is equal to sort of 70 to 80 milliequivalents. So dose is to be calculated in milliequivalents per kg per day. Treatment dose is 6 milliequivalents per kg per day. Prophylactic dose is 3 milliequivalents per kg per day. So ते आयनची जे प्रिपरेशन आहे त्याच्यावर नेहमी चेक करायचं की 5 ml मध्ये किती milliequivalents of elemental iron. Okay, not the total iron, it is the elemental iron. That dose is to be calculated. Okay, I will repeat it quickly. 6 milliequivalents per kg per day of elemental iron is to be given for treatment. It has to be continued first until normalization of hemoglobin, and 3 months afterwards for replenishment of the iron stores. While you have taken all the care, your done, sort of calculated the dose, you have counseled the family, dietary changes are done, everything is going fine. And you repeat the hemoglobin as sir has mentioned that after 4 months and 6 months, and you find that there is no response to iron. You have started patient on iron at the hemoglobin of 6, and after sort of 4 months, 3 months, it is still up to 6.5 or something like that. So you have to go back and check these factors. Okay, you have to check the compliance. If the patient is not compliant with that particular preparation, you may change the preparation. आता बरेचसे flavorचे preparation यायला लागले, so that you can use. As sir Jay sir already mentioned in the introduction, you have to do stool examination to rule out occult blood. There can be cow's milk allergy, there can be little bit of fissure anywhere, there can be malabsorption, and there are so many GI causes. Celiac disease is there. So there are so many other causes which can lead to iron deficiency, and the primary cause is actually GI loss, and it is not the iron deficiency. So if you have given 3 or 4 months of iron, and if the still patient is not responding, first thing I will always do is stool examination. And you mentioned the stool for occult blood for 3 days continue. Okay, this is also important. If you do only one stool occult blood, you may get negative result. You may get positive result, false positive also one. So you do 3. If 2 are positive, label it as a positive. And you have to, of course, rule out chronic disorders such as CKD, pulmonary disorders, GI disorders. Those also you have to rule out. And once you have ruled out everything, you have documented iron deficiency to start with serum iron, ferritin वगैरे सगळं केलं. 3 महिन्या 4 महिन्यानंतर तुम्ही परत हे सगळं कार्यक्रम केला, परत आयन सुरू केलंय. 3 महिने परत झाले, इलेक्ट्रोफोरेसिस करून झालंय, थॅलेसेमिया रूल आउट केलंय, सगळं झालंय. आणि यू आर स्टील फाइंडिंग की अरे दिसतं तर आयन डेफिशियन्सीज आहे, पण रिस्पॉन्ड का करत नाही. So the last thing you do is this IRDA, okay, iron refractory iron deficiency anemia. म्हणजे तुमच्या clear cut iron deficiency anemia आहे. There is no reason to deny it, but still patient is not responding to iron. So what is this? It is an inherited disorder of a systemic iron balance in which absorption of the iron is impaired as well as the utilization of the iron is impaired. म्हणजे iron absorbs होत नाही, तुम्ही देत चालले पण it is not getting absorbed in the body. So how patient is going to respond? Patient is not going to respond. So patients with IRDA will show iron deficiency anemia, which is refractory to the oral iron, and it is partially responsive to parental iron. Okay, it is caused by mutation in a particular gene which is called as TMPRSS6. So what is this gene? It regulates the hepcidin. Okay, and hepcidin is a molecule which regulates absorption of the iron from the GI. Okay, so basically this is a inherited disorder. ह्या disorder मुळे iron absorb होत नाही साध्या भाषेमध्ये. You are giving iron but it is not getting absorbed. So that is a iron refractory iron deficiency anemia. How to differentiate? There are subtle clues. Of course, you have done ruled out and then you are ordering this test, but before that also there are some clues. The microcytosis in IRDA is very severe. म्हणजे आपल्या जनरली आपल्याला 60 to 70 किंवा 50 to 60 मध्ये असतं. This will go even below that. Even the degree of anemia is very severe. It will go up to 6, 7, 4, 5. And ferritin level is also very low. Transferrin saturation is also very low. Okay. And of course, there is no response to iron. There is partial response to parental iron. The remission, transmission is autosomal recessive. And you have to sort of give parental iron in between to these patients. Oral iron with whatever dose you have to continue, dietary supplements you have to continue. And fortunate thing is that most of them, when they go into adulthood, they will sort of get out of this. The exact mechanism why they sort of go into responding to the iron in the adulthood is not known, but most of them will respond to the sort of iron in the adulthood. Most probably the absorption might be increasing with the age or something like that. But even though ferritin level of them is low, anemia is sort of not there in the adulthood. So coming to parental iron therapy, we know that there is very limited role of parental iron. It is limited only for the patients who have some sort of defect in the absorption. It can be because of small bowel resection, inflammatory bowel disease, or malabsorption, or something like that. There are different formulations: iron dextrans, sucrose, sodium gluconate, and we know the most important side effect is hypersensitivity reaction, and because of which most of the sort of pediatric hematologists or even the pediatricians are not very comfortable in giving the parental iron. In that also iron sucrose and iron sodium gluconate are alternative options which have got lesser risk of hypersensitivity reaction. Coming to our second case, 4.5-month boy who presented with increasing pallor. Now, first case we have seen IDA. Now, this is our routine second patient which we all see in our OPD. 4.5, 5 months, 6 months, 7 months, 8 months, whatever is the age you can consider up to 2 years. The patient is coming with pallor. You have seen hepatosplenomegaly, and this is the CBC. Classic anemia hai, MCV low, MCH, MCHC low, IDW normal, reticulocyte borderline high. So microcytic hypochromic anemia with hepatosplenomegaly looks like thalassemia. Yes. So here the peripheral smear is very supportive. You will see all the features of hemolytic anemia such as teardrop cells, polychromasia, nucleated RBCs are there, anisopoikilocytosis is there, and this is very classic of thalassemia major. If we can see the WBC in this patient is in the range of 25,000. Sometimes it is 30,000, 40,000, 50,000. Why? Because these are not actual WBCs. They are the nucleated RBCs. Current Coulter मध्ये काय Coulterला we have fitted the size. Coulter will measure all the cells based on the size. म्हणजे प्लेटलेटची साईज ठरलेली, न्यूट्रोफिलची साईज ठरलेली, लिम्फोसाइटची ठरली आहे, सगळ्याची साईज ठरलेली. लिम्फोसाइटची जी साईज आहे ती सेम साईज न्यूक्लिएटेड आरबीसीची आहे. So all those nucleated RBCs which are there in the circulation in thalassemia are counted as small lymphocytes. So this WBC count is falsely high in thalassemia. And if you have got good pathologist, he will always mention the 20 NRBCs per 100 WBCs. And the corrected WBC count is, means if you have got WBC count of 30,000, peripheral smear मध्ये ते खाली नोट टाकतात की there are polychromasia and all those things, and nucleated RBCs are 20 NRBCs per 100 WBCs, and corrected WBC count is this. So this WBC count is falsely high because of NRBCs, which is a very peculiar feature of any hemolytic anemia. So of course we like to do HPLC, high performance lipid chromatography, which previously we used to call as HB electrophoresis. Only the technology has changed, but it is the same sort of concept, HPLC. So we all know that is HbA, A2 and F, and there is particular range of sort of these hemoglobins for that particular age. And if it is high, we diagnose it as a thalassemia. So what happens to iron in thalassemia? Okay, very interesting. We have diagnosed thalassemia. Of course, most of these patients will also have iron studies done at the time of diagnosis. Serum iron will be increased, ferritin will be increased, transferrin saturation will also be increased, while TIBC in these patients will be low. This we have already discussed. की हे 3 एका रांगेत जातील आणि TIBC त्याच्या उलट जाणार. Okay. Now we will come to an important point which I had mentioned in the start. What is hepcidin? What is its relation to the iron metabolism? So hepcidin is a hormone which is produced by the liver. It is discovered in 2000. It has got pivotal role in iron metabolism and with the principal regulator of iron metabolism. Basically, hepcidin will inhibit iron transport across all cell membranes. म्हणजे कुठलीही सेलच्या ह्या बाजूने त्या बाजूला तो आयनला जाऊच देणार नाही. म्हणजे एकतर सेलच्या मध्ये असेल तर सेलच्या मध्येच ठेवणार, सेलच्या बाहेर असेल तर सेलच्या बाहेरच ठेवणार. दॅट इज हिज रोल. बेसिकली इज लाईक अ पोलीस. He will not allow anyone to go from this side to that side. That is the hepcidin. Okay. गट मध्ये तो काय करणार? गट मध्ये तो म्हणणार की ज्या इंटेस्टिनल इपिथेलियल सेल्स आहेत त्याच्यामधून मी आयनला मध्ये जाऊ देणार नाही. सो इट विल इनहिबिट द ऍब्झॉर्प्शन ऑफ द आयन फ्रॉम द गट. ओके. सेकंड, मॅक्रोफेजेस जे आहेत त्यांच्यामध्ये आयन आहे. इट विल इनहिबिट रिलीज ऑफ दिस स्टोर्ड आयन फ्रॉम द मॅक्रोफेजेस. ओके. सो फ्रॉम गट it will inhibit the absorption of iron, while from the stored iron it will not allow the iron to get into the body. Basically सगळीकडनं बॉडी मध्ये आयन कमी होणार, ऍब्झॉर्प्शन होऊ देत नाहीये, स्टोर्ड आयन पण सर्क्युलेशन मध्ये येऊ देत नाहीये. सो whenever hepcidin is high it will result into iron deficiency. साध्या भाषेमध्ये अजून सोपं करायचं म्हटलं तर जेव्हा जेव्हा आयन डेफिशियन्सी होणार त्यावेळेला हेप्सिडिनला आपल्याला इनिबिट करावं लागणार. कारण हेप्सिडिन जर इनिबिट झालं तर मग आयन ऍब्झॉर्प्शन वाढणार. ओके. हेप्सिडिनचा अजून एक रोल. सो दिस इज द पिक्चर आय विल क्विकली गो थ्रू. ऍज यू कॅन सी इन द लेफ्ट देर इज hepcidin, hepatocyte it is producing the hepcidin. Hepcidin is in the circulation. The diagram you can see circulating hepcidin. So hepcidin will act on small intestine and it will inhibit absorption of iron from the gut. While in the macrophages, as you can see up, it will reduce release of iron from the macrophages. Okay. So iron absorption पण नाही होणार आणि release पण नाही होणार. ठीक है. What is the practical use? Okay, this is okay. Theoretically, hepcidin is a regulatory molecule. We know. What is the practical use? In iron deficiency anemia, hepcidin production is inhibited. Hepcidin is suppressed. It is inhibited so that absorption of the iron is increased from the gut. Okay. While in inflammation, vice versa occurs. Hepcidin is also important in thalassemia because in thalassemia, congenital dyserythropoietic anemia or sideroblastic anemia or all these things, it will actually stimulate absorption of iron. म्हणजे जनरली आपण थॅलेसिमिया मध्ये म्हणतो की बाबा ओरल आयर्न जास्त देऊ नका. त्याचं रिझन इज दॅट म्हणजे खूप बाहेरून ओरल आयर्न प्रिपरेशन्स आर नॉट टू बी गिवन, बट डायटरी आयर्न इंटेक इज व्हेरी लो. While hepcidin will result into increased absorption of iron. Whatever iron is given, it will be increased. Absorption will be increased. So hepcidin is crucial in iron deficiency as well as it is important in thalassemia. Last case, 9-year-old boy who presented with fatigue and pallor. We had seen that there is anemia and hepatosplenomegaly. This is the CBC where we can see there is a anemia. There is a MCV is low, MCH, MCSC, everything is low. So this is again microcytic hypothermic anemia, and there is hepatosplenomegaly and pallor also. We did iron studies and HB electrophoresis. HB electrophoresis was normal, and surprisingly, iron, ferritin, and transferrin, everything was raised. So CBC जो दिसतोय तो iron deficiency anemia सारखा दिसतोय, परंतु पेशंटला हिपॅटोस्प्लेनोमेगाली आहे, त्यामुळे आयर्न डेफिशियन्सी अॅनिमिया असण्याचे चान्सेस कमी आहेत. सो वी एक्सपेक्टेड इट टू बी थॅलेसिमिया, बट थॅलेसिमिया HPLC इज ऑल्सो नॉर्मल. सो आयर्न डेफिशियन्सी पण नाहीये, थॅलेसिमिया पण नाहीये, आणि MCV तर लो आहे, क्लासिक मायक्रोसायटिक हायपोथर्मिक अॅनिमिया. So the next investigation in this patient was bone marrow aspiration, and there were 70% green sideroblast. Okay. So this was actually a case of sideroblastic anemia. This is again a inherited disorder where accumulation of the iron occurs in the RBCs and a ring form of sideroblast are seen. In adults, it is acquired due to alcoholism and lead poisoning. In children, it is inherited as X-linked or autosomal recessive disorder. So this is my last slide. If you get a microcytic hypotonic anemia, where you have low MCV, low MCH, and low MCSC, you should have only these 4 differentials. One is iron deficiency anemia, second is thalassemia trait or major thalassemia basically, third is anemia of chronic disease, and fourth is your sideroblastic anemia. In IDA, as we all know, serum iron is low, ferritin is low, and TIBC is increased. While in thalassemia trait, iron can be normal, ferritin can be normal, and TIBC can be normal, or it can be on a higher side, but it will not be low. Can thalassemia trait have iron deficiency? Yes. Generally लोक थॅलेसिमिया म्हटल्यानंतर आयर्न देतच नाही, तर तसं नाहीये. थॅलेसिमिया मेजरचे जे पेशंट्स आहेत त्यांच्यामध्ये आपल्याला आयर्न द्यायचं नाहीये, पण जे थॅलेसिमिया ट्रेटचे पेशंट आहेत ज्यांचं HPLC तुम्ही केलंय, ज्याच्यामध्ये फक्त HbA2 हाय आहे, HbF, HbA it is normal. So thalassemia trait patients are bound to have iron deficiency anemia, which is prevalent in our country. So these patients should be given iron. Iron can be given to these patients. There is no contraindication to give iron in patients of thalassemia minor or thalassemia trait. Okay. Then there is a third differential is anemia of chronic disease and sideroblastic anemia. I think I have tried to cover most of the things related to iron, and I hope sort of it has given the basics as well as some new things I have been able to add to the knowledge of the audience. And I will be thankful again to the organizers as well as the participants who have taken out their valuable time. Forum is free for the questions.
Thank you, sir. Thank you very much. Moving on for few questions, there are in chat box also. I would like to ask them. Sir, first question I want to ask is, which iron preparation is better? You had mentioned all the preparations in your talk.
All are good.
Yeah, and we also came to know from that absolute and functional iron deficiency, you had elaborated very well. And 3 months of treatment after the replenishing of HB is also most important, what we learned today. And I want to know about that, sir, which iron preparation is better. And the second sub question I want to ask is, at what age the iron infusion is safe? This question means sub question I want to ask.
Yes, iron infusion means you want to ask about parental iron.
Yeah.
Basically, ma'am, no. Actually speaking, most of our patients do not require it, and we should try to. This is my personal this thing, okay? Dr. Nitin Shah, sir, who is our teacher, is very fond of parental iron, so we always get that debate whenever we speak together. So it is a personal this thing. Few people love parental iron because you can avoid blood transfusion when child is in a sort of borderline stage. But somehow I am much scared of parental iron because of the sort of anaphylactic reactions and all other side effects. So this is my personal. Again, I will mention it is not something recommended or this thing, but I feel that I have not tried to use parental iron below 5 years of age. But of course, there is no cutoff that this is safe age and this is unsafe age. But only GI condition is where I sort of try to use parental iron.
Continuing that question, can you stop sharing, please?
Yes, sir.
So continuing that question, at what level of iron do you think parental should be used?
Which should be?
Parental should be used.
Parental iron should be used?
Yes. At what level of hemoglobin?
No, sir. Level of hemoglobin can never be our sort of criteria to use parental iron. Parental iron, I feel, should be used only when there is sort of issue with the absorption. Otherwise, hemoglobin cutoff of 5 and 6 also we have safely used oral iron. And if child is not in failure, hemoglobin is sort of cutoff. 4 is generally, we all know that is not safe where we can sit on the patient. But with the hemoglobin of 5 and 6 also with the proper dietary counseling. Yes, sir.
Yes, sir. You continue later. I will. Yes.
Yeah. So with the hemoglobin of 5 and 6 also, we have started on oral iron dietary counseling. The only thing you need to do is follow them very closely. At least sort of 15 days after starting, you can call them for the follow-up. The only catch here is if patient gets some infection in between. Okay, that is the only problem. Jara infection झाला तर ते 5-6 चा patient सरळ failure मध्ये जातो. Otherwise, if child doesn't get any opportunistic or respiratory or viral, sort of any infection, then most of this, if you get 2 or 3 months of time, most of this will sort of build up their hemoglobin.
Just to miss, though you have mentioned all the irons in your talk, but there is one iron which is colloidal iron, which is having the syrup having the highest elemental iron on in that syrup. Do you think this, because you have said ferrous, the sulfate, and fumarate, and that ascorbate, and then colloidal iron. This whether this colloidal iron is advisable or not.
Colloidal I have not mentioned in my presentation deliberately. Yes. Because somehow many people are using it, but it is again, sir, problem ka hai ki if you want to say that this is not to be used, you have to have some concrete evidence to say it is not to be used. Okay, so we get many patients who have received colloidal iron and there is beautiful response to the colloidal iron. That also I will agree.
Yes.
So by personal experience, I can tell that many patients come and they respond beautifully. But somehow I have not been comfortable in starting it. And recommendation wise, if you go, ferrous sulfate, fumarate, and these are the only salts which are to be used. Colloidal iron, barapiki side effects, staining, the taste also, these are there. Even the GI discomfort also, I have noticed that it is more with the colloidal iron compared to the sulfate and fumarate.
The reason why
response जर म्हटला तर colloidal iron definitely it gives beautiful response.
कशामध्ये
colloidal iron जे आहे टोनोफेरॉन particularly basically आपण जे यूज करतो it does give good response because the elemental iron चे जे content आहे 5 ml मध्ये जवळपास 80 milligram आहे. So the dose is also very sort of less dose.
So the reason why I asked you that because it contains higher elemental, the dose is very small, so it is very convenient to the children they do take.
Yes.
One more reason to ask was that it is prescribed for the most of the infants after the age of 3 months, and that and the brand name you have said, because we should not speak brand name on the forum. So but Colidolline, it is used largely on this on the lot. But the reason recently when I heard in one of the talk, Cordyline should not be spoken by the expert, very much expert. Cordyline should not be used. So, is there any specific reason for not using? I do not know. Of course, I agree, because my personal experience also mostly almost I'm practicing for last 30 years. The Cordyline do give good results. Yes. But when I heard that expert, so probably for last 3 months I stopped using. I do not know the reason. So whether you can clarify that.
I will give you the reason specifically when I read it. But the clear cut this thing is that absorption it's good, but the GI discomfort with the Colidolline is more compared to the these preparations which we are using. That is one valid reason which we have noticed in our practice also. But why definitely not to be used, that also I mentioned in the beginning only, that what to be used is clearly mentioned in the guidelines. But there is no sort of Colidolline विरुद्ध सांगण्यासाठी असं काही specific नाही की why not to be used. Okay, apart from the GI discomfort which is there with other preparations also.
Still that 6 milligram per kg holds true, or we sometimes now we tend to give 3 to 4.
No sir, for treatment 6 milliequivalents per kg per day. For prophylactic 3 milliequivalents per kg per day.
Yes, Jay.
Sir, yes, sir. Please ask. Jay, sir, please ask.
There are studies where even 4 milligram per kg of element and also cures the iron deficiency. That is first.
Yes, 4 milliequivalents per kg per day it can also be used. 4 to 6 milliequivalents is actually newer recommendation. Okay, as sir has mentioned, is it reduced? So it is not. We cannot say it is reduced, but okay, you can use 4 to 6 milliequivalents per kg per day. 6 milliequivalents is not a high dose, but you can try. म्हणजे आता अगदी hemoglobin 8-9 वगैरे आहे, border वर आहे. So you can take your own time, sweet time, and then start with the 4 milliequivalents also.
Another, what is the absolute indication of parental iron? That's first, and whether that parental iron should be used. For example, suppose patient of the injection erythropoietin to support the fast erythropoiesis, whether parental iron in such conditions are used.
Parental iron absolute, and the only indication actually absolute or the only indication is GI discomfort, means GI reason where the oral iron cannot be used. Faster GI concept there pediatric मध्ये especially it is not valid, like in antenatally because that 9 months are crucial, and all those things are there. So if you have noticed, most of the parental iron is used by the gynecology people because they need it for the faster sort of rise of the hemoglobin, and they don't want to give blood transfusion, and oral iron is not sort of sufficient time they don't have. In our case, as I mentioned in the beginning only, that the issue about the fast recovery is not actually valid justification for giving parental iron. That is my personal opinion. Again, I will mention it. I feel that when the HB is more than 5, I have seen many patients doing well, and after 2 months and 3 months, HB has gone up to 8, 9, and even 10 within 3 months only. So I don't feel it justification to give parental iron, because there are reported cases of anaphylaxis after parental iron. So I don't feel that for that reason we should use it. Definitely for GI discomfort, GI malabsorption, and if that is the reason, parental iron can be used. And I have mentioned the 2 preparations which we can use it.
Many years, many years I used to use that iron dextran, and it's really very good to use, and but at present scenario, because I have seen 2 anaphylactic reaction also, but saved, nothing happened, but iron dextran to be avoided. But it gives, because we had used in the children who doesn't take iron preparation, and the limited resource setting, and they totally refuse to take. And when we give, almost alternate day we give for it responds beautifully. But of course, at this forum, not to use iron dextran. That is clear.
तुम्ही ते अगदी प्रॅक्टिकल याच्यामध्ये सांगितलं की ते म्हणजे चवीला मिठाई चांगली आहे, पण तिच्यानंतर शुगर वाढल्यानंतर त्रास होणार, हा तसातला प्रकार आहे की इट इज व्हेरी गुड टू यूज. मोस्ट ऑफ द टाइम्स इट विल नॉट हार्म यू, but once it harms you, it will harm you very badly.
Yes.
Okay, means failed oral replacement therapy. हाँ, ma'am, 2 minutes.
Okay.
Means failed oral replacement is the treatment, means only for rapid repletion of parental means we can give parental iron. But I want to ask you, sir, is there any top-up repletion, especially in case of kidney disease patient or a patient on dialysis? Is there any, it is used for top-up repletion, IV parental therapy? And what
Most
to ask is it better than oral in these cases?
in those cases, actually, madam, erythropoietin helps because the iron deficiency is not the main reason. There, the main culprit is the deficiency of erythropoietin. So that helps you more than the parental iron, and that is used.
Okay.
Can I ask? Yeah.
Yes, ma'am.
Congratulations, Dr. Tushar. Very nice presentation. I just wanted to know what is your take on Tassiron sachets?
Which one?
Tassiron.
Okay. So basically, there are many granules, many sachet, and many things which are coming. But unfortunately, most of them have not sort of proved clinically beneficial and practically useful. मध्ये मध्ये त्या जेलच्या गोळ्या पण आलेल्या.
There was one thing that sprinkler was also there on the daily recommendation basis.
So all those things were marketed, sort of this is better than that as well. But no preparation has sustained test of time apart from your routine syrup preparations. So I feel we should stick to that because in granules and all these things, it is very difficult to measure dose of exact elemental iron. So it is better that we go ahead with the routine syrup preparations.
Okay, sir. Reena ma'am, you want to ask a question?
Yes, one more question from chat box.
Yes.
Tushar sir, is it necessary to do iron studies in all the suspected cases of iron deficiency anemia? Is it necessary?
This is very good question because even though I have mentioned iron studies in my presentation, but is it really essential? So of course no. Okay. If you have got simple straightforward patient of where there is a history of pica, mati khato, kodu khato, he khato, te khato, history of pica is there, platinikia is there is no liver, there is no spleen, there is no lymphadenopathy. You have done the CBC where there is a MCV is low, MCH, MCHC is low, RDW is wide, your reticulocyte count is in a normal range. With clean, straightforward case of iron deficiency anemia, you don't have to do serum iron and ferritin in all those patients. You can straight away start on iron supplements. But if patient has not responded after 3 months, rather than continuing oral iron, just like that blindly, I will advise to document at least once कि खरच iron कमी आहे किंवा नाही. So I think that after 2 or 3 months, if patient has not responded, you should do. Yes, sir. Yes.
Thank you.
Whether I should do reticount at the outset and label later on, this reticulocytosis there, yes, is patient responding to your iron.
Sir, actually, reticulocyte count is very sort of cheap test. It is hardly 200 rupees test, good test. So I feel that CBC, peripheral smear, and reticulocyte count we can do in all patients for that matter. It is very useful test.
Because it has one practical implication. Suppose when you do the reticount, which is low, when you start in a patient before raising of the hemoglobin, reticulocyte increases. So that is the iron deficiency anemia.
Yes. So after 1 month, if you are doing it and there is no response in the reticulocyte count, it is still low. You get a early clue that something is going wrong with this child.
Sir, there is one question from chat box by Dr. Patil sir. How frequently oral iron to be given, once a day or once in 2 days?
Yeah.
He had asked.
Practical is recommended is OD. It is better OD. But आता समजा 10 ml चा dose मी जसं mention केलं 10 kg चा बच्चू आणि 10 ml dose आहे. It is not practically feasible to give 10 ml at one time. So you can divide it in BD. Wherever feasible and possible, try to give it in OD dose because it will increase your compliance also. But there is no harm in giving BD.
Okay, sir. And another question is most important intervention to prevent iron deficiency in infancy. Please comment on it.
Most important is actually complementary feeding. I have seen many patients coming at the age of 1 year. जेवणच नाही बिस्किट म्हणजे 2 बिस्किट खातो 3 बिस्किट खातो किंवा कुरकुरे खातो वगैरे. So good complementary feeding to be started at we know it is now 4 to 6 months. So that complementary feeding should be started. Second point, we all know it is a cow's milk. म्हणजे complementary feed म्हणजे आपल्याकडे काय गाईचं दूध. So we are not against cow's milk. The problem is with the cow's milk is that when they give milk, any milk for that matter, cow's milk or buffalo milk, the other food is not given. So the problem with that is that it is definitely having low iron, and then there is a cow's milk allergy, and all those things are there. But more important than that is की बाळाचं पोट दूध पिऊन भरून जातं. So it doesn't eat anything else. So I feel that the only way or the only measure which is required is good complementary feeding. I think that will solve most of our problems.
Okay, thank you, sir. We are at the end of session. Would like to request Dr. Jay, sir, for a vote of thanks. As Dr. Amol, sir, is busy in another CME.
I
So,
think Mol is there.
no, he's in the CME. Thank you, Tushar sir, for excellent, I think, presentation. Lot of this. Still, I think you can discuss another 1 hour is there, but there is a limit for us. So thank you all the, I think, Dr. Sonali, Dr. Reena, Dr. Renu Madam, Neha, all these present here, and all the audience, and our delegates, petitions for actively known in this today's session are all about iron. And it was an excellent discussion. I think a lot of questions are still there. You can definitely contact Tushar sir for that on this mobile or email we will share on the group. And please keep watch on, again I say, MAHAIP activities, where again on 10th of June we are coming with a very excellent again topic of subspecialty.